So hi everybody, it's really good to be here this afternoon. I'm going to share my screen. It'd be good if I can just make sure I can see you all. Just give me a second. Yeah, hopefully you can see my screen now.
Yeah.
And so really good to be here this afternoon. Mohammed asked whether I would be able to speak this afternoon and share with you around some of the thinking that I've been doing in the recent past. And so this presentation is, as the title says, it's about reflections on Black physical and mental health disparities. So I'm going to talk to you from my observations, some of which include personal experience of disparities that occur for people of Black and brown skin in terms of physical and mental health disparities, and some of the challenges that we need to continuously think about as colleagues in the system, as healthcare providers. What are the key issues that we all need to understand in terms of care delivery in this context? So I'll run through the slide deck. As we've discussed, this has been recorded, and then thereafter, if I can ask you to hold your thoughts, happy to take questions and comments afterwards, at which point we will we'll stop the recording so people can talk freely in terms of questions you might want to pose. So start off with my own personal experience. Who am I? Hopefully many of you know this already, but maybe there's some news to some of you on this. So I'm Nigerian born, and I came to the UK when I was about age 11. And my accent doesn't tell you that actually I've lived in Yorkshire for nearly 30 years. So I do consider myself honorary Yorkshire. Even my accent gives me away as somebody who is a southerner in the UK. And I was brought up in the London area. I'm a healthcare scientist by background in terms of my journey in the NHS. I qualified as a clinical scientist in audiology many years ago. But obviously now I'm an NHS manager, and I'm somebody who, obviously I'm the chief executive here at Airedale NHS Foundation Trust. And I think for me, my career journey is another long-winded thing. How do you go from being a clinical scientist to being an NHS chief executive, and twists and turns and stories that I can tell you about that. But of course, there are many other things that make me who I am. I'm a mother, I'm a sister, I'm a daughter, I'm a niece, I'm a cousin, I'm an auntie. I happen to be Black, I happen to be a Christian, and there will be many other facets. And I think there's something about when we talk about individuals and we talk about people groups, we need to recognize that there are many things that make up different people groups. And even within those groups, there will also be uniqueness around what makes up that individual. So that's a snapshot about who I am as an individual. But I'm going to talk about my life experiences of being a Black woman in England, Black woman experience of the health and care sector. And sometimes it's the simple things that make a big difference that nobody ever thinks about. So, you know, this illustration talks to you about something as simple as a plaster, which is just to cover a graze, a sore that you might have any part of your body, but actually can have a big impact. And I remember growing up that, you know, the only plasters available to me were pink in colour. And so the opportunity for that to meld into my skin, particularly if you're having it on your face or something, actually you're not going to hide that if that's what you wanted to do. But there was an experience that resonated with me when I went to a chemist. I was probably in my early 20s. I wanted to buy a bandage for I think it was for my elbow. I can't remember precisely where, but I wanted to buy a bandage, one of those you wrap around. And I went with a friend of mine who happened to be white, but I was the customer and I was the one doing the talking with the chemist and asking for a bandage. And the lady, in a bid to be helpful, was saying, oh, well, what would you like? These are the different varieties that we have. And oh, look, we have them in very different colours. And we also have flesh coloured bandages, and proceeded to show me something that was pink. And I needed to reflect back to her that, well, that depends on the colour of your skin. So when you say that's flesh coloured and you offer it to me as a black person, that isn't flesh coloured to me. Now, I didn't say all of that. All I simply said to her is that depends on the colour of your skin. And I think this is an experience that happens day in, day out for many people from black and brown communities, for whom actually there is little thought given to the experience, how things work for them, what are the key issues that you need to be considering when you're interacting with people like that. So I want to give further examples of what I would call skin tone bias that we don't think about, and the inequalities that come with that. So as caregivers, pain is one of the things that we would want to say we might recognise readily. I have been a patient on an A&E cubicle in the NHS in England, writhing in pain. Junior doctor is attending to me, and a couple of nurses walk past the cubicle, and then they turn round and they say to him, "You might want to give her some morphine." And the junior doctor who was in front of me says, "Are you in pain?" And for me, that his lack of recognition is because he's looking for different signals. He's looking either for a flushed face, he's looking for a drained face. He's not going to see that in me. That's just one example. If we talk about looking for meningitis in children in particular, it affects adults as well. When I was growing up, the recommendation to parents was hold a glass on the person's skin and look for the purple rash. If you hold a glass on my skin, you're not going to see a purple rash. And so the advice to people from black communities, to people who are brown skinned, the equivalence isn't there. And so when we talk about health inequalities, these are the examples of health inequalities that we're talking about. These are the institutional approaches that introduce bias to the way we provide care. And so we need to spend more time thinking about these key issues and about how do we make sure that we're supporting individuals either in understanding themselves, or actually how do we understand those individuals. And I think this is critical, and that plays up in a lot of the things that Black people experience when they interact with us, because actually the lack of thought to the uniqueness or the differences that exist, and therefore how we adapt our care delivery, is something we need to pay more attention to. So I'm going to take this further on. And I don't know how many people have ever seen a Black fetus. But when you look at medical illustrations typically will have illustrations that are based on the white community. And so the ability of healthcare givers, professionals, to understand what to look for when working with individuals in the Black community is very limited, because the experience is not there. The understanding is not there to understand actually what I'm looking for. So I've talked before about you're looking for the flush of the skin, but actually you're not going to see that. You're looking for paleness, the drain. You're not going to see that. And therefore, it's really important that actually the adaptation that's required to really understand what that difference looks like. And one of the reasons why this slide is really pivotal for me is the recognition that we know that Black people, Black women, are 4 times more likely to die in childbirth and twice as likely to have a stillbirth than white people. And some of that is because of the lack of understanding and lack of recognition around the progression around where a mother might be in terms of her pregnancy, in terms of the stage she's at, in terms of approaching readiness to deliver a baby, the understanding about when she might be in crisis, her baby might be in crisis, and how you might respond to that in a timely way. And so these inequalities hamper diagnosis, and they definitely hamper treatment. And so there's something about what do we do to improve this? And Chidi Ibe, who I don't know personally, but it's somebody I came across on LinkedIn, and we are now connected in all sorts of social media platforms, is doing a lot of work in this area around medical illustration to bring to the fore the considerations that we need to bear in mind when we are interacting with people who are not necessarily from the same community as ourselves. So the same thing applies for a Black person working with somebody who's from the white community. The cues you're looking for will be different, but invariably, majority of the textbooks, if not all of the textbooks worldwide, will reflect white skin approach in terms of what you will see in a white skin, but you won't find one for Black skin or brown skin. And therefore, it's really important that we pay more attention to these issues and that we own it and that we start to understand how we adapt to this. And some of it is in the language that also exists. So often people will talk about strong Black women. And it's something that I always find fascinating, because how do you know somebody's strong? What is your definition of strong? And often the reason why people, I would argue, people talk about strong Black people or strong Black women is because of the inability to detect in that person anything that tells you anything otherwise. And so because you don't learn to read the emotions of a Black person, you assume therefore that they must be strong because you can't see the vulnerability in them. Your inability to read vulnerability does not therefore mean the opposite exists. And therefore, actually, how do we adapt our approach to, for me, is really important in our thinking around these things. However, there is a little bit of emerging awareness, and I was really pleased last year when the issues around Streptococcus A arose in children. And there was the anxiety that was spreading across the country around, this might be affecting my children, what do I need to do about this? And for the first time in my career, NHS England put out messaging that also reflected what you can see in somebody with a dark skin. And for me, that's dipping a toe in the water to do what we need to do more of, increasingly, and understand about actually the same thing doesn't apply to everybody. And so we need to be mindful of these key issues as we go forward, and that we don't continue to perpetuate, not introduce, but continue to perpetuate the bias that exists in our working environments. And this extends also to mental health services. And we know that the statistics are very clear. People from a Black and brown community are more likely to be admitted for mental health challenges than a white person, and be over-medicated, over-medicalized, because of lack of understanding about the presenting features of that person. The stigma that therefore that's attributed to them, the way they are treated under the Mental Health Act, can often be over draconian and very excessive, and actually then creates a revolving door for somebody that either may not have had a mental health challenge at all, or a very minor issue that could have been dealt with in a different way. And the data is there to support this. This is not about happenstance. This is not about guesswork. This is absolutely about what work are we doing to really understand this. And for me personally, one of the things I find very interesting in our narrative nationally, not just in the health sector, is the concept of Black culture. And I would challenge anybody to explain to me what Black culture is. Black culture does not exist in the same way that white culture doesn't exist. But we put a narrative that suggests there is a Black culture, whereas actually there are different cultures within people who happen to share the same skin color. And sometimes, dare I say, people who are Black might share the same culture as somebody who's white. They just happen to have different skin color. But the narrative talks about Black culture. I'm a Nigerian. I don't know how much I have in common with somebody who's from Jamaica, or somebody from Kenya who happens to be Black, or somebody from Australia who's Black, or somebody from Hong Kong who's Black. So this notion of Black culture is something that we need to start to dispel and really stop and think when we are engaging with individuals, and also ask ourselves about actually how we're setting up our services, how we're responding either collectively or individually to people, and actually how we're adapting that so that we are not exacerbating the bias that exists in our system. And I think there are opportunities for us. There are things we can do. So for me, it's not about pointing the finger. It's about encouraging us to think about what can we do differently. So I've given the example of medical illustration. How do we improve the training in medical school, in healthcare professional training, so people look for broader examples. They look broadly in terms of when they want to make diagnoses, their treatment options. How do you know that development is happening in the right direction, or that actually some of it has paused? How do we advocate when we see things aren't going in the right direction? Our responsibility in that is really important. Making sure that we can constructively challenge opinion and approach. And I have personally witnessed when a Black person attending a dermatology service where the consultant suggested that the reason why their skin was appearing the way it was and was causing them a little bit of distress was down to the fact that there was a concern about their hygiene. There was no evidence around that, but that was all that was offered. And so for me, it was my opportunity to challenge that assertion. But actually, what I would say is that the individual concerned, the patient, if I hadn't been there, that patient would have ended up being a DNA. So we talk about patients as being the DNA, but the reason why they would not have attended the next appointment was because they were insulted by that clinician who did not take the opportunity to really understand what was happening for them. And it had nothing to do with hygiene. They had an underlying autoimmune condition. But you had a consultant who threw away a comment about actually maybe your hygiene is what is in question. So there's a lot of work that we need to do around this. Continue to support and understand better those who have Black and brown skin in terms of their mental health. What are we interpreting as mental health issues, as opposed to what might be a cultural difference? That cultural difference is not reflective of their skin. It just happens to be who they are as an individual, what shaped them to where they are today, and how do we hold their hands to help them get them to where they need to be. But most importantly for me, we need to keep talking about this. It's not about hiding it. It's not about pretending it doesn't exist, but it's about saying, how can we continue to do better? Because I think we are doing better, but we can't afford to rest on our laurels. But it is really about how do we continue to do this better and create an environment that's inclusive for everybody. That's everything I wanted to say. Happy to take any questions, comments. Please feel free to push back, and I'm going to take my screen down. Thank you.
Thank you, Foluke. I'm just going to stop the recording, folks. Bear with 1 second.